I think that you know, pregnancy is a obviously unique time in our patients' lives, and it is something that you know, all of us come across. We come across pregnant women, so I do think that it's important, and so I do thank you for the opportunity. Just before I start, I have put together a PowerPoint presentation just with some of the information on it. I can't see if anybody has asked any questions or raised their hands. So Chris, maybe if you could stop me as we go along, if there are questions that people want to ask along the way, because with the screen share, I can't see that on the Zoom screen.
Sure, I'll happily do that.
Okay. All right. So, you know, when I think about pregnancy and I think about just want to get going here. There we go. And whenever I talk to colleagues, students about pregnancy and other medical conditions, in my mind I divide it into two parts. And the first part is what pregnancy does to the disease we're thinking about. Specifically, what happens to the disease incidence, what about the disease severity, and does it change the complications that we might see? And then the second part is what that disease might do to the pregnancy. That we can divide into trimester-specific complications, and obviously in the first trimester we always worry about miscarriage and teretogenicity. We can look at labor and delivery. Big thing always is vertical transmission. When we're looking at infective diseases, does this have the potential to infect the fetus? And then we can look at postnatal problems. So what about COVID-19? Well, early on, we assumed from the information we have on other respiratory viruses, and notably influenza A, H1N1, SARS, and MERS, that pregnant women, and we know in those diseases that pregnant women are more vulnerable to these diseases, and when they acquire these diseases, we're more likely to have severe disease, that they were more likely to be sicker than their non-pregnant counterparts. And so we expected the same to be true for SARS-CoV-2. The early data, though, didn't support that, and although these were case reports and small series, they came from a wide variety of areas, from China, from New York, from the USA, and from Italy. And initial data suggested that there was no increased risk for acquiring SARS-CoV-2, that there was no worse disease severity, and that most of these women who acquired COVID-19 would recover with no need to deliver them. There was then a systematic review published in June 2020 online, and in fact it's just been published now in August in print, in obstetrics and gynecology, looking at the rates of maternal and perinatal mortality and vertical transmission. And they looked at the primary outcomes were maternal ICU admissions, which you can see was only 3%, maternal critical disease, which was 1.3%, and maternal death, which they reported as 0.0. Their secondary outcomes were preterm birth, cesarean section rate, and vertical transmission. The conclusions from this study were that it did not seem as though there was more severe disease in these women, that there didn't seem to be an increased death rate, that vertical transmission seemed very unlikely, but that there were significant changes in obstetric outcome. That's at preterm birth and cesarean section. They did list quite a few concerns with the study, and one of them is that a lot of these patients included in the study came from the Chinese cohort, and so that slanted the data quite significantly. Also, the areas from which these patients were recruited, there were big differences in the obstetric management. And so, for example, the preterm birth, a lot of that was because the clinician decided it might be better to get the baby out, and not necessarily because of maternal fetal compromise. So we'll talk a bit more about that just now. The other thing that they looked at was that the study included symptomatic and asymptomatic patients, and it depends how the patients are screened for testing, what your outcomes or what your figures are likely to be. So if you are only looking at women who are tested because they have symptoms, then obviously that gives you a different cohort to a general population screening where you're likely to pick up a whole lot of asymptomatic patients who are coincidentally positive at the time. But more recently now, subsequent to that, the CDC has published a surveillance report and where they raise concerns about the effect of COVID-19 for pregnant women. They also say that pregnant women seem not to be more susceptible to infection, although that may be related to a bias in that pregnant women tend to isolate and avoid exposure more because of this inherent caution. They don't want to expose themselves and their babies to COVID-19. But what they did find is that pregnant women who acquire COVID-19 are more likely to be admitted. They are more likely to be admitted to ICU, and they are more likely to be ventilated. Again, the study showed that the mortality was not increased compared to the non-pregnant cohort. So that's quite reassuring that seems to be coming through from numerous different reports, is that the mortality rate doesn't seem to be higher. But these women, specifically in the third trimester, do seem to be getting sicker. They subsequently then recommended that pregnant women follow the same general prevention measures as far as social distancing and hand hygiene and masks, which we all know very well by now. But they went a step further to suggest that pregnant women who have older children need to be cautioned in that those children may be infected, and while they may be asymptomatic or have mild infections, they could then expose their mothers, and this could then result in COVID-19 in that pregnant subgroup of women. The Royal College of Obs and Gynae has listed pregnant women as a vulnerable group, particularly those in their third trimester. In their data, they see a preponderance of admissions after 34 weeks or in the peripartum period, and comment that management of pregnant women with COVID requires increased vigilance. They have made specific recommendations now surrounding pregnant women in the workplace. And of note, and this is something that I got asked about quite often early on, was what about pregnant healthcare workers? The Royal College, in conjunction with the Royal College of Midwives and the Faculty of Occupational Medicine, have now in the UK come out with guidelines for NHS health workers, where they stipulate quite clearly that women who are over 28 weeks should try and avoid face-to-face patient contact and look at telemedicine video consults. So Babington roles should be administration roles. That's an interesting autocorrect there. So that was interesting. That was published just recently as well on the 30th of July. So that's a little bit about the incidence and severity. If we talk about the symptoms in pregnant women, are these any different to the non-pregnant patients? Well, no, the features are very similar. Specifically, fever and cough are quite common, but we also note that there's quite a large overlap between the common pregnancy symptoms of fatigue, shortness of breath, nasal congestion, nausea, and vomiting. And I often have patients saying to me when they've come for antenatal appointments that the screening questionnaires to get into our facilities are a bit difficult because a lot of their normal pregnancy symptoms are on those questionnaires. So I think for our pregnant patients, we have to emphasize that we're looking for new onset of symptoms. We're looking for a rapid change in symptoms, and obviously we have to have a high index of suspicion if there's a known high-risk contact. I did see a question just pop up. I'll carry on.
Bronwyn, can you hear me?
Yeah.
So the question is just, what is our experience in SA?
Okay, so I'll give you a little bit of the South African data coming through in a minute. I actually can pull up some of these questions. Does that then come onto the screen if I open the questions?
We don't see it on our side. I think you'll just see it on your side.
Okay, perfect. Okay. So knowing that these women then are likely to have an increased risk of being more severely ill, and this is a triage recommendation that was published in the Respiratory Journal earlier this year for non-pregnant women, but is equally applicable to the pregnant population. Where patients coming into a casualty environment, I'm sure we all are getting very used to making quick assessments, looking at their SATs, looking at their respiratory rate. But in pregnant patients, we need to be aware that their oxygen requirements are higher. So for pregnant women who are requiring assistance as far as maintaining those oxygen saturations, with high flow nasal oxygen, we may not get the same clinical response, especially in late gestation. If the mother's obese, if she's carrying a set of twins, or if there's polyhydramnios, so that increased intra-abdominal pressure does affect the efficacy of the high flow nasal oxygen. We also know that one of the measures that is often used is proning patients to try and improve gas exchange and ventilation, and this is difficult with a uterus that's more than 24 weeks. It is possible. You can provide padding under the patient's shoulders and hips, but that padding is very important. You need to make sure that when you prone the patient, the pregnant uterus isn't putting pressure on the vena cava, because aortic caval compression is going to drop the blood pressure significantly. Also, then, if we look at PEEP, when we get to high PEEPs, that does tend to decrease preload and reduces cardiac output. Mean arterial pressure is very important for placental perfusion. So in patients that require high PEEP, we need to make sure that we are aware of what the effects can be on the fetus. So as I've said, the fetal well-being requires adequate oxygen supply, and so we need to maintain maternal oxygenation over 94%, and the PaO2 over 70. The HB dissociation curve is important, and that's to maintain oxygen moving from the maternal side of the placenta to the fetal side of the placenta, and pH plays quite a critical role there. And then obviously uterine blood flow. So we've got to have oxygen in the blood. It's got to be able to cross from the mother to the baby, and it's got to actually get to the placenta. So we need that uterine blood flow, and that is affected by maternal hypotension, hypercapnia and hypercapnia. And then remember the medications, the patients that are on inotropes for hemodynamic support. So this is quite a unique situation where we're treating two patients, and so we have to maintain the oxygenation above what the mom alone would require. And as I said, we need that 94% to get adequate oxygenation to the fetal-placental unit. The local experience, we're starting to hear from colleagues that are working in units where they are treating quite sick patients, and they're noting that these patients do tend to deteriorate quite rapidly, that if the respiratory rate is under 30 and SATs are over 94 and 40% oxygen, those patients seem to cope. But certainly if there's no improvement of the respiratory distress on 40% oxygen, then they initiate high flow as a matter of urgency. And this is coming from Dr. Buga out of Barra. In pregnant women, especially if they've got an increased BMI, as I said, be warned that the response to high flow and nasal oxygen may be poor. And so you need to be planning to intubate those patients sooner rather than later. And yes, in advanced gestations, there is a place to consider delivery, and I'll go into that in a little bit more detail just now as well. What about steroids? We've heard lots, and I see it's all over the press today about the reduced death rate in our ICU since dexamethasone was introduced as part of the management protocol. So in pregnant women with severe disease who would meet criteria for steroid use and are at risk for preterm delivery within the next 7 days, the initial standard obstetric regimen is what's recommended, and that's either betamethasone or dexamethasone. So the betamethasone is 2 doses. We use a shortened course, so we give 2 doses 12 hours apart, but the original studies were for 2 doses 24 hours apart, or the dexamethasone, which is on the COVID protocol, 6 milligrams given as 4 doses 12 hours apart. And that then is to provide fetal lung maturity and to help with other conditions associated with prematurity, including necrotizing enterocolitis and intracranial bleeds. It's then advised that we consider changing the steroids to complete the maternal course to either prednisolone or to hydrocortisone, because it's only the fluorinated steroids that cross the placenta. So if we change the steroids, we then reduce the fetal exposure in utero. There is some concern that long-term steroid or repeat courses of steroids in utero does have an effect on these fetuses. So this is a recommendation that's coming out of one of the American papers, that we start with the standard dexamethasone and then look at converting to complete the maternal course. I'm going to leave that there for a moment. I think that I've tried just to pull out things that I thought were specifically relevant to pregnancy. Obviously, all the other things that have been covered in the lectures up until now hold true for pregnant women as well. But I really thought to try and just highlight some of the things that are more specific to pregnancy. I'm going to go on now and look a little bit at what COVID-19, what effect COVID-19 has on pregnancy. So one of the questions that I've been frequently asked in the last few weeks is from patients who are either planning to fall pregnant and are wanting to know whether they should go ahead or whether they should wait, or from patients who have already fallen pregnant. Certainly in those early few months, April, May, they were already pregnant when this all started to hit. So currently we've got no specific data with regard to the teretogenicity or miscarriage rates related to SARS-CoV-2. Numerous resources are saying that vertical transmission is probable, but it does seem that it's not common. There have been cases where viral particles have been found in placental tissue, where babies have had IgM at the time of delivery. So it does look as though it's probable, but certainly not common. What we do know is that the other coronaviruses are not teratogenic, and certainly we haven't seen any reports as yet of increased rates of abnormalities coming out of Europe or Asia, where they had the earlier outbreaks. The problem with a lot of this data is that it often does take a little while to filter through. What we do know, though, is that pyrexia in and of itself can cause abnormalities, and especially high prolonged fevers, specifically some cardiac abnormalities, but definitely neural tube, and that the high pyrexia and maternal illness can also be associated with miscarriage. So patients are advised that if they are unwell, to use paracetamol to control their temperatures, to have plenty of fluids, and to rest. So that's not a specific COVID effect, that's more of a general illness effect. What about falling pregnant? Well, previously when we were giving patients advice about whether or not they should be looking to start pregnancies, we talked to them about maternal age, we talked to them about their fertility history and how difficult or easy it had been for them to fall pregnant before, what the age of their other children was and the age gap between their children. And given that there are no specific risks reported to COVID-19 as far as miscarriage and teretogenicity, the two major bodies in the American College and the Royal College don't suggest that pregnancy should necessarily be avoided. I do mention to all of my patients who ask me about this, though, that they need to consider a couple of things. The one is that when they're pregnant, they are out of necessity going to have to access the healthcare system in some form, or there is going to be interaction, and so that then comes with a degree of exposure. Even with a normal pregnancy, but specifically should they have complications, something like an ectopic pregnancy or miscarriage, which unfortunately happened pre-COVID times and will continue to happen, and so they may need to access for emergency care. And then the other thing that I discuss with them is how different the emotional experience may be for first-time moms, but also for moms who are embarking on subsequent pregnancies. Most of us are still asking our patients to come to their antenatal appointments alone. There is definitely a heightened anxiety amongst these women about what potential risks there are for themselves and for their pregnancies. And then the delivery comes with consequences in that they don't have the friends and family support that they might otherwise have had. Family often live elsewhere in the country, even family that are living close by, contact is restricted and limited. So those are factors that I think they should be considering when thinking about whether or not to fall pregnant. What about later on in the pregnancy? Well, as I said earlier, in the late third trimester, women do seem to have higher rates of severe illness, and there's definitely an associated increase in preterm labor and in rupture of membranes. Of note, though, is that there is a significant increase in iatrogenic preterm delivery, and that's seen even with mild disease. In fact, in some of that data coming out of China, in the studies, the indication for Caesar was purely COVID-19, and that was in moms that weren't particularly ill. And this is for a couple of reasons. Firstly, clinicians often want to deliver and avoid having to deliver once the mom is really sick. So there's a fear that the maternal disease is going to progress, and they'd rather deliver while the mom is well. The second reason for an iatrogenic delivery is to improve the maternal condition, and there are pros and cons to that, and I'll come back to that in a moment. But obviously, in the very sick mom, we know that if we can reduce her oxygen consumption, if we can make ventilation easier, if we can make things like turning patients prone easier, that may well have benefit. But then the third is to reduce a potential risk of fetal hypoxia. So there's definitely place for delivery in a sick mother or a compromised baby, but what a lot of the early studies were showing was that deliveries were being undertaken in case these things happened, even if they hadn't happened yet. Looking at what the UK data shows us, of those who were admitted with COVID-19 and delivered, their preterm delivery rate was 27%. Now, the preterm delivery rate worldwide has kind of been stuck for a couple of years at 10%, and it's one of those things that a bit of a bugbear for obstetricians is that we just can't seem to get the preterm delivery rate much lower than that. So we know that a rate of about 10% is average, and a lot of the studies are now quoting preterm delivery rates between 20 and 30%. And you can see there that of those deliveries, 47% were for maternal compromise and 15% for fetal compromise. The rest of those preterm deliveries were spontaneous preterm labor or spontaneous preterm rupture of membranes, which then progressed. Of note, though, is from this UK data, there was also 10% of term babies who required a neonatal ICU admission, and that for various reasons, one of which being the fetal compromise that prompted the delivery. But that is much higher than we would anticipate from other term deliveries. We spoke about antenatal steroids or steroids to treat COVID, but what about if we need antenatal steroids for the pregnancy? Initially, there was some concern about giving moms, certainly with asymptomatic or mild disease, steroids in the fear of suppressing immune systems and whether that would then promote disease progression. However, the current recommendation is, given the known benefits of antenatal steroids and the impact it has on morbidity and mortality related to prematurity, that pregnancies between 24 and 34 weeks, where delivery is likely in the following week, steroids should be given because the benefit outweighs potential risk. What about magnesium sulfate? So we in this country know that we use magnesium sulfate quite extensively in women who have severe or imminent preeclampsia or eclampsia as a seizure prophylaxis. We also use magnesium sulfate quite widely now for neonatal neuroprotection if we're planning delivery with a baby that's less than 32 weeks. It's a significant reduction in cerebral palsy if we can load the mother with magnesium sulfate. There is a caution, though, with giving magnesium sulfate to moms, certainly admitted moms with COVID-19, in that the magnesium can cause respiratory depression. So it does need to be individualized based on the maternal condition, and it should be a multidisciplinary team input where available to decide on risk versus benefit. And obviously these moms need close monitoring. Please also just remember that magnesium is cleared by the kidneys. So women who have got a reduced urine output tend to land up with higher levels of magnesium and an increased rate of magnesium toxicity. On preeclampsia and COVID-19, this is quite an interesting one, and I think it's something we're probably going to see a lot more of, especially in this country where we do see a lot of preeclampsia. We're starting to see reports of an association between COVID-19 and a preeclampsia-like syndrome, and it's really not surprising given that we know there's such a strong vascular component of COVID-19. as I said, there is a preeclampsia-like syndrome that's been described in women with severe COVID pneumonia. And at the moment, it is all observational data. The study that was published in June this year looked at routine bloods that we would pull for patients with preeclampsia, but they also looked at uterine artery pulsatility index, the SFILT, and the insulin-like growth factor. And what they saw was that the specific markers for preeclampsia in these women were normal. So when they looked at the ratios, there wasn't a preeclampsia type ratio that they picked up. And what was interesting was that in these women, symptoms of preeclampsia resolved as the maternal COVID pneumonia improved. So what this study suggests is that COVID-19 can cause preeclampsia, and that's the hypertension and endothelial dysfunction that we see related to the inflammation and cytokine release, which we know is a hallmark of severe disease with COVID. As far as thrombotic events go, well documented as well that COVID-19 is associated with vascular events, and that any person requiring admission for COVID-19 receives anticoagulation. Pregnancy is, of course, in and of itself also a hypercoagulable state. And so any pregnant woman who requires admission for any medical problem should be anticoagulated. And the same holds true if we have pregnant women who need to be admitted because of COVID-19. Important, though, that these women may need higher doses. So the enoxaparin is the anticoagulant of choice, but they may need higher doses than the standard dosing regimen. And so anti-10A level monitoring is required to make sure that we are providing them with an adequate dose. Tranexamic acid has been in the literature quite a lot, and we use it for patients who have postpartum hemorrhage. We've had some good studies showing that early use of tranexamic acid in the management of patients with a significant postpartum hemorrhage reduces mortality rates. There is a concern, obviously, using something that's antifibrinolytic in a disease process where we're worried about VTE. So there is a caution about using tranexamic acid. And again, like everything else, it's risk versus benefit. As far as non-pregnant women, I thought I would just pop this in at the bottom. There's a feeling amongst the critical care specialists, the hematologists certainly, that if any female is ill enough to require admission from COVID-19, that we should strongly consider stopping their oral contraceptives and their HRT to try and mitigate that increased VTE risk. What about delivery? So there are a couple of things. We need to look at the timing of delivery, and then we need to look at the mode of delivery. So in our patients who are asymptomatic, there's really no reason to intervene. We can continue with the pregnancy, deliver as planned, and ideally that will be at 39 plus weeks. So we try and avoid elective delivery less than 39 weeks, unless there's an obstetric indication. And that's for all patients, not just for the subgroup. So the patients who are asymptomatic with a positive COVID test continue with delivery as planned. In patients who are preterm and have got mild to moderate disease, no medical or obstetric reason to expedite delivery. The recommendation is that we try and delay the delivery, allow the patient to recover, come out of isolation. It's obviously going to be safer for the mom and for the newborn if the mom has recovered. There's also, if the mom's got antibodies and you pass some of those antibodies across the placenta to the baby, then that will potentially give the baby some degree of protection after delivery. The caveat to that is that we know that in this disease, it's often the second week that the symptoms are worse and that our patients are sicker. And so we just have to bear that in mind when we're making decisions to delay delivery. And that's possibly where a lot of those iatrogenic deliveries, preterm deliveries come from, is by the concern that in a week's time you might actually be in a worse place than you are at the moment. For severely ill patients, there's still many uncertainties. One of the big controversies is whether we should be monitoring the fetus in a mom who is acutely or critically ill. And it's something that needs to be discussed with the patient if she's able to discuss it with you, with her partner. It needs to be a decision taken by the team. If we're going to monitor the fetus, then we have to be prepared to intervene and deliver that baby. And obviously, the moms that are critically ill, the question then is they're not able to physically labour and deliver vaginally. So then we're going to subject them to a surgical procedure, and we then got to look at anesthesia and analgesia as far as how we're going to do that in the safest possible way. And then the last thing, obviously, is the timing of delivery. The recommendations is that at 32 to 34 weeks in patients who are admitted but not intubated, that's possibly a good time to consider delivery. The reason being that babies that are born between 32 and 34 weeks generally have a very good outcome. So their long-term neurological outcome is good. And so you're getting the benefit as far as improving mom's ventilation, potentially making her care easier, and then protecting the baby from potential exposure or to hypoxia. If patients are intubated and struggling with ventilation, then that's a different discussion altogether. And I do know that a lot of our units have put together almost an ethics committee, a group of clinicians, so that when they are faced with these difficult decisions, that it's not one person to make the call, that it is something that can be discussed amongst a group of colleagues to come to a decision. What about the mode of delivery? Well, most authorities say that we should reserve Caesars, even Caesars in COVID patients for obstetric indications, and that COVID alone is no reason to alter the mode of delivery. Like I said to you earlier, the China data, most of those women were delivered by cesarean section. But there's been a small study coming out of Spain, and it's less than 80 women, so it really is a small study, published in JAMA, also now just recently, a month or two ago. And they looked at 37 women delivered by cesarean section compared to 41 women who delivered vaginally, and they showed an increased risk for maternal clinical deterioration following the cesarean section, which again I think is not surprising. We know that we defer elective surgery in patients who have respiratory illnesses. So if a patient was coming in for a hysterectomy and had influenza, we wouldn't operate on her. We would postpone the surgery because of exactly this risk. The numbers are small though, and there is a potential bias in the study in the way that cases were selected. So we're going to need bigger studies to give us better data. What about the anesthesia and analgesia? Well, the spinals and epidurals are valuable for these situations. If we've got patients, certainly mild to moderate disease, the spinal epidural reduces the cardiopulmonary stress, and that's one of our biggest risks of exposure to our units is from labouring moms, because in the second stage of labour, when they're exerting themselves, when they're pushing, that's when the viral spread happens. It's very difficult for those moms to keep their masks on when they late second stage and have those expulsive efforts. They're pushing, they're working hard. Women who've got an epidural, that effort is significantly reduced. Also, if these women require an emergency cesarean section, the epidural could be topped up, and thereby we'd avoid the general anesthetic, and so we avoid the aerosol generating procedure. We do avoid nitrous oxide, firstly because the cleaning of the masks and the filters become a problem, also because there's a concern about increasing viral spread through droplets. As far as post-delivery analgesia goes, there's a caution about PCA pumps because of the respiratory depression with the opioids. And then obviously we remember from the early days there was a concern about non-steroidals. And although we haven't had other studies coming through that support that, it would be prudent to use lowest dose and the shortest possible time. What we have done with our anaesthetists in our facility is we've actually put together a COVID positive post-op cocktail, with the aim being that the pharmacy can dispense it as a package so that there's not scripts and people going backwards and forwards from the unit to the pharmacy, but also looking at a combination of drugs and medication that can largely be self-administered by the patient so that the nursing staff can take it to the patient, but where we avoid suppositories, where we avoid anything that's given intramuscularly. So looking at an oral regimen to avoid close contact between the staff and the patients. Looking at the postpartum period, these women, we do need to consider VTE prophylaxis. So we need to look at their pregnancy risk factors, we need to look at the mode of delivery, and then we need to consider their COVID status. Any woman who is COVID positive at delivery, and especially if she's delivered by cesarean section, should receive VTE prophylaxis. For the duration, and this is somewhat debatable, but for most women who get postpartum VTE prophylaxis, short term is 10 days and long term is 6 weeks. So our patients who've got thrombophilias or previous DVT, they would be on the longer term, but short term prophylaxis is 10 days. And so that would seem to be a reasonable duration to put these women on to Clexane post delivery. Another caution in these women postpartum is to watch closely for fluid overload. They're very prone to pulmonary edema. We know that from our patients with preeclampsia as well. So if we've got patients who've got COVID-19, who've got a preeclampsia type component, and then have a spinal or an epidural anesthetic with a lot of intravenous fluids to maintain their blood pressures, they are at high risk of decompensating and going into pulmonary edema post-delivery. Other postnatal considerations is what do we do with the baby and how do we manage the mom and baby situation. Internationally, we aim to keep mom and baby together if the mom is well enough to look after the baby. So obviously if the mom is critically ill, then mom and baby are going to be separated, and you can consider in that situation discharging the baby home to a well family member who would then take care of the baby. If the mom is either asymptomatic or has only mild symptoms and is able to care for her baby, we advise keeping baby in a crib, where possible having a curtain separating the mom's bed from the crib. When mom does attend to her baby for changing nappies, for feeding, breastfeeding is supported. We recommend the mom practices good hand hygiene, wipes down her breast, and wears a mask while she feeds. Again, there is advantage to the breast milk. We know that there's huge advantages to the baby from breastfeeding, but it's also hoped that the mom will be then able to pass some of those antibodies through the breast milk to her baby. We need to think about bonding. It is hard. We are separating these moms. If the mom is tested positive around the time of delivery, she's isolated from family. She's isolated from her support structures. And often for our first-time moms, they're not getting as much contact from lactation consultants, from that whole support structure that would ordinarily be there, from a doula perhaps who would have come in to help her had she not contracted COVID. So those are factors that we have to look at, and we also have to look at moms who are separated. So, for example, we've had a baby who had to be admitted to the neonatal ICU because the mom was COVID positive. She wasn't allowed visitation. So there are issues that have to be addressed, and because of that, we have to be even more vigilant as far as asking about and looking for postnatal depression. So all of the societies have recommended that we try and restrict our post-delivery visits to televisits, to telephone calls or to video calls, and it can be difficult to assess a patient's mood or state of mind if they're not sitting with you in the consulting room. So it is something just for all of us to bear in mind when we do see women who are postpartum, is to make sure that they are coping from a postnatal depression point of view. I'm going to finish there with you know, this is a disease that we are still learning about as we go, and the situation's fluid. What we're sure about today, we question tomorrow. We need to be open to new ideas, to changing the way we manage patients, and to sharing knowledge and skills to achieve the best possible outcome for our patients. And it's one of my favorite Helen Keller quotes, is that alone we can do so much. So I'm going to open the floor to questions. I thought that I would start with that, give you an overview of what I felt were important points, and then take questions from the floor.
Perfect. Thanks so much, Bronwyn. That was a really great overview of the considerations in pregnancy. Just as a reminder to the audience, you can either type your questions in the sidebar or raise your hand, and we'll unmute you so you can verbalize your question.
Okay, so Chris, should I just go through the questions that have been raised there?
Yes, please do.
Thank you. Okay, so the first was our experience in SA, and I did touch on that we're hearing data coming from colleagues at Charlotte and at Barra. There are a couple of big data collection studies running as well that pregnant women can be enrolled in, pregnant women with COVID. So hopefully we're going to see more local data coming through in the next couple of weeks. It's always been a problem, is that we tend to have very little local data, but there is a big data collection team running to try and give us some better local data. What are the risks to pregnant women with other comorbidities, e.g. HIV? Absolutely, and that's was touched on in the recommendations that the Royal College has made to the NHS as far as pregnant healthcare workers, in that they say there that pregnant healthcare workers who are less than 28 weeks can continue at work if the risk assessment is favourable, but that pregnant women less than 28 weeks with other comorbidities should have non-patient facing roles, so they should be taken out of the clinical scenario. So definitely there's an acknowledgement that when you start to add other comorbidities, the risk for pregnant women does increase. I think also, I mean, I'm sure you know that one of our biggest problems at the moment in South Africa is access to chronic medications for our patients with other comorbidities. And with the fact that they're not necessarily are accessing their HIV medications, their TB medications. So that's another complication that COVID has created. Then the DOACs in pregnancy. DOACs are not registered for use in pregnancy. We don't use any of the oral anticoagulants, the novel or the new oral anticoagulants in pregnancy. There are still units that are using the older one, but the new DOACs are not suitable to be used in pregnancy, not for breastfeeding either. So although they are nice to use and that you can take them orally, that the monitoring is easy, and that they certainly are much cheaper than the enoxaparin, it's not an option for our pregnant patients. Just quickly going through. If the mother and father tested positive, would it be considered to allow dad as the birthing partner? The answer to that is unfortunately no. And that's because of an exposure to our staff and to our unit. Certainly in our unit, that would not be a possibility. So in our unit, we are testing all of our elective admissions. So our patients coming for elective cesarean sections and our patients coming for planned induction are tested prior to admission. And if the mom tests positive, then she is delivered in a separate area, so outside of our main labour ward. We can isolate her, and in that area we do not allow any other support people. And I think that, you know, I must say our patients have been quite understanding and accepting of that, you know, exposing then our nursing staff and our medical team to 2 positive patients as opposed to 1 positive patient. So unfortunately, no, we would not allow a positive dad in for a positive mom in our units. I can't obviously speak for all of the other units.
Actually, Bronwyn, if I could maybe just ask kind of along those lines, we've had some discussions around it. And now with well, I guess with the change to the 10 days, it does also make things a bit different, and then hopefully a bit easier. But with the asymptomatic parent, would the consideration be any different?
You mean so a positive test in an asymptomatic parent?
Yes.
Yeah. You see, so this is a discussion that unfortunately I've had to have with numerous of my patients in the last couple of weeks. We in Gauteng have had a major surge sort of early to mid-July. And so we did have situations. We had situations where mother was negative and dad was an asymptomatic positive. And those positive dads have not been allowed access into the unit. And in fact, when the mom and newborn have been discharged, we've advised them to continue isolating at home for the full 10 days from the time of dad's test. And that, you can imagine, is very hard for families to do. Equally, if the mom tests positive, even if she's asymptomatic, we're managing her as a positive patient. The problem is that while lots of studies are saying that perhaps the asymptomatic positive patients don't shed as much virus, that's not true for the patients who are pre-symptomatic. We've got no way of differentiating which patients are. I mean, there might be people on this group who know far more about this than I do. I'm not a virologist and I'm not a physician, not an infectious diseases specialist. But our understanding is that we don't have a way of, when we get that positive result back in a patient without symptoms, of knowing whether they're going to remain asymptomatic or whether they are pre-symptomatic and in 2 or 3 days' time they are in fact going to then display symptoms, and they will have been quite infectious in that time.
Yeah, but yeah, it makes perfect sense. It's a very tough situation, I think, especially tough on the families and the parents at the moment.
And Chris, just to mention, I mean, I've had to phone patients and give them these results, and the response has changed dramatically in the last sort of 6 weeks. Initially, when we were phoning people, there was an utter disbelief. People were quite horrified that there was any, how can this be? I haven't been anywhere. I haven't seen anyone. I haven't, Invariably, though, down the line, the pathway becomes clear. I've still got 2 or 3 patients who've got no clue how they got it. But, you have a patient who says, don't know where this came from. I haven't been anywhere. I haven't done anything. Then 4 days later, you hear from the family that they have now developed symptoms, and actually they were in contact with another family member who's now also been positive. So unfortunately, we have to take every positive as a true positive and potentially infectious. And to our patients, it is a hard time. I mean, pregnancy and childbirth is supposed to be this happy time, this joyful time, this time of celebration that everybody wants to join in. And now we're saying to them, you have to restrict access, not just in the hospital, but baby showers once you go home afterwards, and everybody wants to come and see your baby. But we just have to, and I keep reiterating to my patients, at the end of the day, what our aim is to provide you and your baby with a safe birth experience. And the safest way for that to happen is for the mom to come to the delivery COVID-free, for her to have her delivery, and for her and her newborn to go home COVID negative. And so that is our responsibility, is to make sure that we can, as best as possible, provide that. So I'm advising my patients to, as far as possible, isolate from 36 weeks. My rationale is that if they stay home, and it's easier for the pregnant moms to do that than for their partners who are often still working and out and about. But if they stay home, even if they have been exposed, we know that most people who are going to develop symptoms will do so by day 7 to 11 maximum. So that means that if they were exposed, if they then isolated for 2 weeks, that gives them time to recover from it, hopefully, before they come for delivery. So by 38 weeks, even if they have contracted it, they should hopefully be over it.
No, I think that's definitely kind of the safest and most sound approach.
Yeah.
I'm not sure. Sorry, Karen? Sorry, Bronwyn, were you about to say something else?
No, that's fine.
Cool. So I'm not sure if I've seen any other questions coming up. So I think we'll probably start wrapping up. Just as a reminder to everybody, there won't be any other sessions this week, and our next session will be next week, Tuesday, So next week we'll run it on Tuesday and Thursday, just go a public holiday. Then the week after we'll return back to Mondays and Wednesdays again. Mandy, are you there online? I'm not sure if Mandy, if you can unmute, but I was just going to mention the next lecture. So our next session will be next week, Tuesday, as I mentioned, on cardiac manifestations in COVID by Dr. Nahi Levine, one of our cardiologists at Mill Park Hospital. But I don't see any other questions there. So, Bronwyn, I think we can wrap it up. Thank you again for joining us tonight, and thank you especially for all the time and effort you put into tonight's talk. It really was good and a really good insight into something we don't hear a lot about during these times of COVID. But thank you all for joining us as well, and we will see you next week, and have a good long weekend and a happy Women's Day to all our women out there.
Thank you muchly, and thank you again for the opportunity.
Pleasure. All right, keep on, everybody. Have a good evening.